Hello, 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 hello. I have so many hellos built up from so much time not being here, and I'm thrilled to be back. Partnered. Uh, the word partnered is a very ironic word to use today because my partner, the one and only Carol Lau, is presenting. But my other partner, Prof. Rez, is on his way. Thrilled to be here. Happy Friday, everyone. Thank you all for joining. With a special thanks to Kara for presenting on a night shift. Hello. I'm mixing my yogurt now, by the way. That hello is a cue for you to say hi to people.
Me?
Yes, you, please. If you don't mind.
I'm so sorry, guys. I'm so delirious. I'm just coming off a night shift. Hello. Hello. I can't match you, Rabih.
Yeah, you can. You always can. Outdo me every day. How was the night shift?
Very busy. We
Yeah.
had 10 holdovers. So I'm semi-functional, but I'm so excited about this case that I still wanted to present to you and Rez.
And you said Rez, and then I see a big smile. Hello,
Welcome back, Kara and Rabih.
Hello. It's so good to see you. How are you, Prof. Rez?
I'm well. Is my voice coming through?
Oh, it just came through really. It was like soft, and now it's perfect.
Oh, beautiful. Hi, Kara. I hear you got a case for us.
Yeah, it's hard on purpose. No, I think you guys will get it in the first aliquot, but I think it's really good teaching. I'm really excited to hear from you, Prof. Rez.
Oh, you're too kind. How was Japan? Welcome back.
I want to move there, but don't tell Rabih.
Well, he texted me that he also wants to move there. So you guys are on
I told you not to tell her, man. Well, what a great way to do VMR round 2 and hang out with you guys. Super excited. I will tell you that the only advanced knowledge I know is that there are pictures involved. So Kara, your co-host, feel free to share your screen whenever you want. And I'm feeling some magic to kick us off. You want to take Alcott 1? All right. Okay, let's rock and roll.
Okay, this is a 39-year-old woman who presented to the emergency room in so much frustration because she was told she had eye allergies and they haven't gone away. In fact, they've gotten so much worse.
Kara, oh my gosh, I'm gonna love reflecting back on this case where we're just starting with this eye allergy, then it's gonna be some epic twists and turns and such. I will be very brief here. Whenever someone is coming with inflammation or conjunctivitis, so inflammation of the conjunctiva, the very thin layer over the sclera, the top 3 causes to consider is, like she's diagnosed, allergic conjunctivitis, some kind of viral conjunctivitis, or some kind of bacterial conjunctivitis. This ends up leading the DDX for conjunctivitis. But already we need to pause here. Why do we need to pause? It's the fact that she's coming frustrated that these episodes keep flaring. So now we have to step back from the run-of-the-mill allergic conjunctivitis and ask the question, are we dealing with a recurrent red eye? Because ultimately, that's and by the way, I'm sort of translating eye allergy into allergic conjunctivitis. I'm not sure if that's actually the case, but that's the initial lay of the land. Whenever a problem is recurrent, you need to pause and ask the question, was your initial hypothesis incorrect? I'll leave it at that, but we've had a recent RLR where Rabih presented a case from Japan of a patient with recurrent flares of diarrhea and abdominal pain who ultimately had probably A20 haploinsufficiency. And as a bad teacher, I'm not going to even explain what that is. Rabih, anything to add before we get some more data?
No, but I'm really nervous because Kara said we should get the diagnosis in the first aliquot. I'm like, what? No, absolutely no chance. So, all right, we've already lost Prof. Rez. No, I think that's absolutely superb. I have nothing to add. All right, Kara, tell us more, please. Would you please?
I'll answer a couple of questions in the chat with the HPI. So she initially noticed 2 weeks ago that she had like bilateral eye redness, and that prompted her to just go in and be seen because she'd never had both sides like this before. And progressively over the next 2 weeks, she started to have more pain and the redness wasn't going away. And so she was seen by, I think, a couple of outpatient providers, some urgent care, some her primary care, who initially gave her like eye drops. They told her to try things like antihistamines or like Zyrtec or Claritin. And she did all of this with really no improvement. In fact, she noticed, I'd say a couple days ago, that she was starting to have trouble reading the numbers on the clock. And that's what prompted her to say, like, enough, I'm coming to the emergency room.
That's terrifying in many ways, because whenever people have their eyes involved and things are not getting better, that's a big red flag. As Prof. Rice said, and the truth is that most conjunctivitis, be it allergic or infectious, the hardest thing to do is on day one when you're taking care of the patient and trying to make a prediction. It becomes much easier on the subsequent visit to move past conjunctivitis because of one fact. Almost all conjunctivitis has spontaneous resolution with or without antibiotics. Even bacterial conjunctivitis, the reason we hem and haw about using antibiotics is the recognition that even if we miss bacterial conjunctivitis, it actually is a naturally self-healing process. So the very fact that we're here is a massive red flag that we have to think beyond the conjunctiva and think about other causes. And I'll pass the mic to Prof. Rez in a sec to discuss where his thoughts go about that. But I think this is a great opportunity to practice what red flags should we gather on day one to have ideally arrived at this conclusion sooner. And that's not a criticism of the people taking care of the patient in this case, because the very process that we do is imperfect. And I have been on this side of the calculus many times and still try to use the opportunity to practice. So when somebody shows up with a red eye, the first thing what you're trying to do is you're trying to see, is this a surface issue or a deeper issue? That's the calculus. Not all benign causes of red eye are conjunctivitis. There's two other things, or really three other things, that are also benign. One is blepharitis, or inflammation of the eyelid, usually as a result of either mild infections or allergic reactions. So you'll see that the eyelid is what's really red, blepharitis. The other is a subconjunctival hemorrhage. That's when your patient has a hematoma right behind the conjunctiva that's very, very benign and no different than a bruise on the back of the hand. The third is actually the most common. It's dry eye. So when patients' eyes get irritated and they get dry, just like dry skin, eczema, it can get red and irritated. So those four things are very, very common causes of red eye: conjunctivitis, blepharitis, dry eye, and a subconjunctival hemorrhage. Now, all those things have a very reassuring list of red flag symptoms. And all of those should be not accompanied by pain and should not be accompanied by loss of vision. And so if those are present, the patient immediately should be triaged beyond those things. But those are rare because they're very, very specific. If you have vision changes or if you have pain, those are very suggestive. So you're trying to find something a little bit more sensitive. And there are two things that are fairly sensitive. One is discharge. If you're dealing with a surface issue, that surface should be oozing. And so if there is no oozing or discharge, that's a big red flag. Very, very helpful. And then the other one is the pattern of conjunctival irritation. Where is the conjunctiva irritated? To understand that, you really need to visualize the eye socket empty without the eye, and realize that there's a bony structure that's waiting to accept the eye, and the eye slots in here. And what protects the eye from being exposed to the world? It's the conjunctiva. So the conjunctiva is basically like saran wrap, wrapping the eye on the outside, protecting it from the exogenous world. And that saran wrap has a little hole in it. And that hole is where the cornea pops out so that your interpretation of light is unaffected by the conjunctiva. So the only part of the eye that doesn't have the conjunctiva on the outside is the cornea. Okay? So if the conjunctiva is primarily diseased, you'll see that it'll be irritated on the outer margins, further away from the cornea, because that's where the majority of the conjunctiva is. However, if you see irritation of the conjunctiva close to the cornea, called, so the pattern is called the ciliary pattern, meaning that the core center part of the conjunctiva is irritated. That's a sign that the irritation is not coming from the outside, not the peripheral margins, but coming from the inside eye structures like uveitis or scleritis. So to summarize, common helpful red flags are the absence of discharge and a central conjunctival irritation. Very, very, very helpful. Pay attention to those. By the time the patient's having pain or vision changes, it's often a little too late. So pay attention to the sensitive findings. No discharge and central irritation. All right, Prof. Rez, thoughts?
Well, my thoughts is, when did you do your ophthalmology fellowship?
Urgent
That
care,
was
my
such-
friend. Thank you.
Oh my gosh, that was, it reminds me of the hour you taught me about passive range versus active range of motion. The only way Kara can upset you is if she doesn't tell you what's going on centrally versus peripherally. But Robbie, that honestly, that was like so amazing, because I'm sure you see so many red eyes there in the emergency department. And as a hospitalist, I don't see the red eyes until we're dealing with a sinister pathology. And I think the best way to approach this for the sinister causes, and we have reasons to approach the sinister causes. Why? Because of the trouble reading and the eye pain. Those are red flags. It's just to think about the anatomy of the eye. And so what I'm going to do here, because I think a picture speaks 1,000 words, and this sort of highlights everything Robbie said with regard to the cornea being that only opening without the conjunctiva. Then you have the conjunctiva right here. You have the sclera right here. So you can take an arrow, or let's be a little more benign and less aggressive, a laser pointer, point it at the eye. And so if you're saying what causes a red eye, that can be of sinister etiology, well, look, you just go through the layers here. You come right here, you have the sclera. So you can have scleritis. And scleritis, there's a more benign cousin of it, which is episcleritis. And we can actually distinguish that on physical exam, but we won't just yet until we get more data from Kara. And then as we come forward, you see here's the iris. So now you can have iritis. And this is when you get into the domain of uveitis, where there's anterior uveitis, there's posterior uveitis, and there's panuveitis. Usually, if you can see the red eye, and if it's due to uveitis, it's more likely to be anterior. So the fact that we're seeing the redness tells us that there's something going on here in the anterior of the eye that probably is extending beyond the conjunctiva based on the pain and the blurry vision. But you have to be cautious. You can't just anchor on the anterior surface of the eye and say, oh, could this be keratitis, scleritis, anterior uveitis? Because the patient's having trouble reading. It could be due to problems in the anterior, but who knows? Could they have a retinal problem? Could there be an issue with the optic nerve? So I think based on what Kara has presented, we're concerned. We know there's pathology in the anterior of the eye. We haven't ruled out pathology in the posterior of the eye. And what this would make me do is ask for extraocular symptoms, because once we start invoking uveitis, scleritis, optic neuritis, the question becomes, are we dealing with the systemic disease? And you might say, wait a minute, the patient didn't complain of joint pain or fevers or, chest pain, but the eye is what's bothering the patient the most. So sometimes you have to ask the question to understand if we're dealing with an extraocular symptom that can help guide our DDX. Back to you, my dear friend, Kara.
Oh, I'm like learning so much. I can't tell you centrally or peripherally is that I thought it was red, but we can talk a little more about that. I'll take you all the way to the physical exam. So to answer some of the questions, so there's pain in both eyes and redness in both eyes, and the pain is worse when she moves her eyes. She has the only associated symptom she really has is a headache that is only on the right side that really seemed to start when she got teeth braces, which had been on for 5 years. And she wasn't really having like it didn't spread anywhere, but she was noting that maybe she had some ringing in her ears when the headache was onset. No discharge, maybe a little bit of tearing, but it was clear. And then her review of systems was otherwise like pan negative. Notably, she was seen by optho in April briefly for what she thought was like right eye double vision, but that resolved and she was lost to follow up in that setting. And so she doesn't have any other past medical history. Her past surgical history is only significant for a pelvic laparoscopy for an IUD that migrated. She has no known allergies, and the only things she's collected on her outpatient medications are the plethora of eye drops and anti-allergy medications. Her social history, she lives in SF with her husband, has 3 kids, sometimes works cleaning houses. She's lived in San Francisco for about 20 years, and prior to that lived in Mexico. And then she doesn't use any substances, doesn't really have a family history of anything as well. And then I'll quickly take you through the exam. Her vitals, she has basically normal vital signs. Her physical exam is really only notable for like what looks like injected like sclera and conjunctiva bilaterally. She can like count fingers maybe with her left eye, but really can't make out anything else. It's so blurry. There is reproducible pain with extraocular movements. Interestingly, she is able to like note movement in her periphery. And we didn't have a Snellen chart to opto's chagrin. Let me see. Yeah, otherwise her review, her physical exam was relatively normal. There was like no synovitis. There was no like discharge that we noted. It was pretty much a normal physical exam otherwise.
I think this is super helpful, Kara. And what I'll do is I'm going to leave the exam for Rabih, because I think we would all benefit from hearing his approach, given his experience and expertise there in the emergency department. I'll comment a little bit on this, on the HPI. And now I'm actually going to comment on the patient's age and use some of the epidemiologic clues that we have. The moment where in the past where she had an instant of diplopia, you have to be a little cautious in concluding that it was for sure diplopia, because when someone has diplopia, ultimately what it means is that the eyes are misaligned. And if you cover up one eye, it usually resolves because it's an issue with the extraocular movements. But sometimes it's hard for patients or for physicians to characterize diplopia from blurred vision. So before we entertain or try to create a DDX for diplopia, we can, I think, appropriately assume cautiously that maybe this was that initial flare of the blurred vision of whatever ocular pathology this patient might have. The headache is not surprising, though the fact that it's localized maybe adds a little more support to something extending posteriorly from the anterior eye and involving the CNS, because the eyes are the gateway to the brain, as are the ears. Then you look at her age and you know this is a young person. She's 1 year older than Prof. Rez. And so very, very young, in fact, and young people are at risk of everything that everyone else is at risk at, but also you can get a flavor of potentially an autoimmune phenomenon. Being the gender and the age, it would be very consistent with that. Oftentimes, when we evaluate a patient, we're like, could this be infection? Here, I would say, could there be something autoimmune going on? So I'd love to pass the mic to Robbie to sort of share his thoughts with regard to the physical exam and where that puts us at.
It's so interesting, isn't it, Prof. Rez? And I think it has to occur in the context that you just laid out, that this is a person who's given a sniff of eye history before and who's otherwise young, very, very young. And so this very, very young person has a really interesting exam. And I think that you just got to have a little bit of context. And I'm so glad for the experience in the emergency room, because it helps me here in an unexpected way. It helps me because I've never seen this before. I've never seen somebody have such degree of compromise, even though I've seen uveitis and scleritis before. So you have to ask yourself the question and start logically. This conjunctiva is injected bilaterally. Is it an outside job or an inside job? And the fact that it's refractory and bilateral and causing pain almost confirms it's an inside job. So is it then keratitis, inflammation of the cornea? Is it scleritis, uveitis, or is there something else in addition to those things going on? And the big red flag that there might be something else going on is the fact that she has vision loss. So most patients with uveitis or scleritis or even keratitis will not have such degree of vision loss to the point where they can barely count fingers. And so for me, I'm wondering whether she, in addition to her anterior involvement, has posterior chamber involvement, such as posterior uveitis, posterior scleritis, retinitis, or as inferred by the pain worsening with eye movements, optic neuritis. So why do we have this buzzword of pain with eye movements from optic neuritis? It's because when the eye, anterior part of the eye, when it moves, it's not moving against anything. There's no friction. The posterior part of the eye, when it moves, and if it's irritated, it is moving against the bone, but it's not innervated. The posterior eye is insensate. So what distinguishes the optic nerve? The optic nerve is coated in the meninges. And when the optic nerve is irritated, it can cause a headache. And you're literally moving the source of the headache when you move the optic nerve, when you move your eyes, irritating it. So we have a classic description of findings of optic neuritis, which is vision loss and pain with eye movements. So now I think you have to wonder, is this a pan-ocular disease ranging from the anterior chamber to the posterior chamber to the optic nerve? And I'm really, really worried about that possibility. And so what would happen next? I think you need an expert to take a look at this patient's eye with a dilated fundoscopic exam. The additional tools that I'm aware that ophthalmology has, which is to do a fluorescent angiography, which assesses the retinal vessels to look for retinal vasculitis, and then also potentially an MRI to look for posterior optic neuritis, which may not be seen on the exam. So those are the tools that people have. The real question, I think, for us is, which is in reality, was what internal medicine diagnoses, what diagnoses can we help establish in this instance? And I think I can't emphasize the role of basic blood work and a chest x-ray. The chest x-ray here is to look for subclinical involvement of sarcoid or worst case scenario TB, which this patient is at risk for given her previous residence in Mexico. And blood tests that are going to be key here, absolutely key, are a basic analysis of the systemic system, renal panel, liver panel, but this is a patient who you want to get an HIV in, and you also want to get an RPR. And the latter, the RPR, is really the only thing that I can think of that causes panocular inflammation, all the way from the cornea to the optic nerve. So even though this patient is a woman, reducing her risk of syphilis, even though she's married, further reducing her risk of syphilis, I think that it's not zero, and the syndrome is concerning enough for it. But long story short, the vision loss here is a big red flag that something posteriorly is happening. It could be uveitis, scleritis, retinitis, but the pain with eye movements is most suggestive of optic neuritis. But you definitely need somebody to confirm that. Any other thoughts come to mind, Prof. Rez?
A 0.
Alrighty, Kara, tell us more, please.
So, couple of things. We initially tried to get an MRI. She has braces, so she can't get the MRI. Obviously opso was consulted urgently in the setting of acute or maybe subacute vision loss. And we took some pictures. And I will show you the pictures. So we'll start with this guy. Can you see it? Okay, and then let me see if I can pull up a video. Okay. Okay. I don't know if you guys want to talk about what you're seeing first. Before I tell you a little more, but what I can tell you is that all of her basic lab work was negative. Her chest x-ray was negative. And her RPR was non-reactive. That's what I have for you. And then if you talk briefly, I can tell you a little bit more about what we got next.
Kara, may I ask, are the images showing optic disc edema? Is that
yes, for the initial retinal image that you saw, you're seeing, I can pull that up again, but you're seeing where did it go? You're seeing like blurring of the optic disc margin. You're seeing or like complete loss of that kind of like cup shape.
And then the second image, can you describe what the findings are for that?
Yeah. So what that image is, and I can play it again really quickly, is I don't know what camera they used, but it is a image of the back of the eye. And you're seeing detachment.
Got it. Retinal detachment. Okay. So, Rob, maybe I can just take a quick stab at this, and then whatever you have to add to that would be stellar. And I think, I'll talk about the optic disc edema. We dived deeply into this topic on a prior human diagnosis case. And really the important thing to start with here is just optic disc swelling. And the question becomes, are you dealing with a bilateral process or unilateral? In this case, we've so far seen one of the eyes, but it seems the patient has problems in both of the eyes, if I'm not mistaken. And so when you're dealing with bilateral, assuming you're dealing with bilateral optic disc swelling, your DDX really comes down to either true papilledema, which is a consequence of increased intracranial pressure, but there really is no reason to suspect an intracranial mass. Venous sinus thrombosis is important to consider in a young woman, especially if they're on OCPs and at our risk of clot formation. We're not really getting a flavor of hydrocephalus. I know the patient couldn't get an MRI because of the braces, but I think it's less likely. Idiopathic intracranial hypertension is always important. We didn't get the patient's weight. They often complain of headache worse in the morning when they're lying supine because you take away the effect of gravity and alleviating the intracranial pressure. And then for the pseudopapilledema, there's no hypertension, there's no clues for extraocular features. So none of these diagnoses add up. So the question becomes, are we dealing with bilateral optic disc swelling? If we are, have to consider true papilledema. But for some reason, this case is also, we have to think about optic neuritis. Why? Because of the reasons Rabih mentioned. So where I am, Rabih, is in the true papilledema, but more likely based on the pain with the movement of the eye, this sort of inflammatory ocular disease. without extraocular, manifestations. And so there, we're linked with infections, which can be viral, run-of-the-mill, Lyme, syphilis. The syphilis RPR came back negative. There could be false negatives for the non-specific treponema test. And that's why many times we do the reverse test where we start with the more specific treponema antibody. So I think it would be really important to rule out syphilis, as Rabih mentioned. I can't imagine TB just being in the eye and not showing anywhere else. And we're not in Lyme territory where Kara is. For the autoimmune processes, there are some autoimmune processes, but like Cogan syndrome, but I don't know if Cogan's actually causes an optic neuritis, and we're not getting flavor for these other S's of lupus and Sjogren's. MS is so important to consider, given the age, given the demographics. Oftentimes they complain of colored vision, and they can come with optic neuritis, but we have anterior involvement of the eye, which would be odd for that diagnosis. So I want to pass the mic to Rabih to also reflect on the images and where we are in the case. But if I were to summarize it, seems like there's optic disc edema. There's also anterior redness of the eye in someone without extraocular features besides the headache.
Yeah, Prof. Rez, I'm right there with you. I completely agree. And I'll just take a second to emphasize how unusual it is for people with anterior chamber involvement to have vision loss. And I think the biggest thing in this case is to recognize like what's causing what. And she has anterior chamber involvement because the eyes are red. And then she has vision loss because their optic nerves are involved. And I completely agree with you. I think, when you see the patient without systemic hypertension or findings of elevated intracranial pressure who has optic nerve swelling with pain, your working diagnosis should be optic neuritis. And if you just pretend that all you know about this patient and you know nothing else is that she has optic neuritis, the assumptions you will make based on base rate are that it is in one eye and that she has no anterior chamber involvement. Why? Because the vast majority of optic neuritis is either idiopathic, where it might represent a first phase of multiple sclerosis, or related to MS, and that's over 50%. So you immediately break through the base rate right away because she has bilateral disease, which would then, if you just say that, which would then get you to think about neuromyelitis optica and other CNS diseases. But if we're frank about what we know about her, we know she has a central nervous system issue because she has cranial nerve 2 involved. And then we also know she has a surface level issue. She essentially has a neurocutaneous disease. And even though the distance between the front of the eye and the central nervous system is millimeters in length, the geographic traversation of this disease process is going all the way from basically the skin to the brain. That's massive. And it's very, very unusual. So for me, I think not only are we dealing with a rare syndrome of optic neuritis, we're dealing with a ridiculously rare manifestation of it being bilateral and involving the anterior surface. So where am I at? I think whenever there is so much disease traversing from all the way to the skin to all the way to the brain, I think the clues will come with finding, well, what's in the middle? And for me, I think all the autoimmune diseases that are CNS restricted are gone because of such prominent surface manifestations, and they account for the vast majority of optic neuritis. So what would I do? I think I would do exactly what you just said, which is to say, is there an infection that could be going on here? Is this a false negative RPR for sure? Does she have cats at home, and could this be neuroretinitis from Bartonella for sure? Is this TB? Gosh, I mean, I agree with you that it would be so weird for TB to show up this way, but are we missing something because we haven't CT'd her chest or something like that, So I think the journey is now, this is a systemic disease with anterior involvement and posterior involvement. Is there any other systemic involvement? And my priorities initially will be to make sure that her treponemal serologies are truly negative, to wonder if she has any Bartonella exposure, and then to query the possibility of TB. And then after that, I think we can go into the autoimmune causes that are even less common, but important to think about, but only after the infectious stuff is negative. And yes, I will no way in hell get this diagnosis on aliquot 1, let alone aliquot 9, maybe. We'll see.
I don't know, you know, esoteric stuff. Um, so, Optho used some very specific words when they described this. They called this bilateral serous retinal detachment, and that kind of hypoechoic space between where you're seeing the retina lift off of the back of the eye is filled with serous fluid. Something else to note is that we were able to do a little bit of digging, and like the full autoimmune panel is negative. There's no ANA, there's no dsDNA, there's no RNP, there's no Sjogren's, there's no RF. The infectious workup is totally negative. She doesn't there's no, it's a quant gold is negative. There's no, I mean, we didn't send off specific Bartonella antibodies, but she got further CT imaging of her head and chest, and there's no evidence of disease there. I mean, I think I'm one step away from the final diagnosis. I don't know if you guys have any final thoughts, but I think that both ophthalmology and rheumatology were very focused on the fact that this was a serous retinal detachment. And that's all I really had to go on when I was Googling around on UpToDate. But I will let you guys take a stab at it, and then I'll let you know what they all decided on.
I have no idea. I just know of this condition called central serous retinopathy, which usually occurs in young men, actually. A patient develops a retinal detachment in the context of nothing, just being alive, or with steroid exposure. So you could put a narrative that she actually had some conjunctivitis, got steroids, and then developed central serous retinopathy from that. Which would make our hypothesis of optic neuritis, which really was, yeah. So I guess, Prof. Rez, I'm really not sure what the answer is, in large part because I'm not sure what the problem is. I'm not sure if we're just solving a retinopathy problem without optic neuritis, or we're solving a neuroretinitis, a nerve problem plus an optic nerve problem. I'm also not sure now if the anterior involvement is requires explanation, or was a initiator for something in the back of the eye. But I think you certainly start to make more progress by labeling this as just an isolated optic issue. And so is this a optic restricted systemic disease, or is there so much content knowledge about the serous nature, which I don't really understand. I just know of this condition because I had a patient with it. So I wouldn't know how to be confident in getting to the bottom of this process. And I would learn a lot from Neuro and Opto. Where are you at?
First, I just want to thank Kara for bringing this case. So many stellar teaching points were made along the way, and you presented it in such a great way. And I Googled the serous retinal detachment, and just reading the article, the one disease I've never heard of, but that came up is Vogt-Koyanagi-Harada disease. And so I don't know. I would look into Harada disease. It affects people 30 to 40. Men and women are equally affected. And that's the extent of my knowledge based on what Google is saying. So I'm not gonna speak anymore because I have nothing to add. I would love Kara to educate us at this juncture.
So Optho and Room, in the setting of what they were framing as isolated bilateral serous retinal detachment with panuveitis and some concern for tinnitus, for a diagnosis of Vogt-Koyanagi-Harada disease. This is a central nervous system condition that really specifically affects vision and hearing, and it's exceedingly rare. It's a genetic condition. And it seems to involve some kind of specific targeting of T cells to melanocytes, causing like non-necrotizing granulomatous formation. And it's very isolated to the eyes, but I think bilateral serous retinal detachment is like, especially in the isolated sense, is really what tipped Oppo off to this, like from the very beginning when they had done the fundoscopy. That's really all I know about it. I haven't had a chance to really read more about it because I've been doing a residency thing, but I do want to read more about it. From what I understand, it's often a diagnosis that you have to make after you've ruled out other systemic autoinflammatory conditions and infections. And once you do that and you really are assured that this is an isolated finding, that in a woman in her 30s and 40s who is Latinx in ethnic origin, it is more concerning for, she has like multiple risk factors for this as well. Yeah.
I'm going to give the mic to her. I just want to say I love this clinical exercise. Thank you again, Kara. And Rob, you know what this reminds me of? When Messi dribbles past the entire opposing team and then puts the ball on the goal line for someone like Samuel Eto'o to just kick it in. Anyways, thank you for being my Messi, my man.
Oh, Prof. Rez right before the buzzer says it, and then in true Prof. Rez fashion deflects all the credit. That was absolutely amazing. You know, I can't wait to dive into this and learn much more about it. And in the interim, while Carol's pulling up, I pull up my Evernote and basically had it's amazing how you can read about something and completely forget about it. So this is a classic presentation of VKH, and I had completely forgotten about it. And I actually had a patient in residency and in my R2 year who was admitted with this condition, and that's where I learned from it. But clearly I've forgotten it, and it's a great opportunity to practice it again, which I'm really, really, really grateful for. And I think for me, the place that my mind was struggling with a lot is the optic neuritis. So I'm curious, Kara, did Opto ascribe that label too? And does that, okay. Can you, yeah, they said she had panuveitis and central serous retinal detachment. So what was their interpretation of what looked like, to me at least, that the optic nerve was blurry? Is that where the detachment was, or what's the explanation for overusing optic neuritis in this case?
Yeah, I think when I asked them for the images initially, they were really focused on the fact that like you lost the structure that you normally see. They were trying to dumb it down for me because I really didn't understand what I was looking at. But they were like, you're losing that structure of the optic disc, which is like usually that very crisp, and like it's not so much like a papilledema or like an edema so much as it like as the like structurally you've lost that. And then it was confirmed with whatever special camera tool thing they had that you saw in black and white that actually visualized the detachment and the serous like the serous kind of encapsulation from like where that detachment was. And so what I took away from that was that it was a loss of structure, and that the reason why they didn't go further into like calling this optic neuritis was that like it was bilateral, which was weird. And then that they just had a better tool to like confirm without MRI, because I think like if we had gotten the MRI, it would have been more obvious to us that this wasn't something like more intracranial that we were dealing with. And they just had a tool and the context to understand that what they were dealing with was a loss of structure as opposed to like an inflammatory process.
Yeah, I mean, I learned 3 like really cool things. Thank you for that. The first is, if you're solving the wrong problem, you have no chance at arriving at the right diagnosis. And this whole time, my mind was solving the wrong problem of optic neuritis. And one big retrospective clue was when we were saying, Prof. Rez, this is so weird. It's bilateral optic neuritis with anterior involvement that breaks the base rate. But whenever you're breaking the base rate, you have to stop and be like, well, are you just solving the wrong problem? That's why it seems so unusual to you. And the third concrete fact I'll learn is how central retinal detachment right next to the optic nerve can fool you into thinking the problem is in the optic nerve. And then, of course, read much later about VKH, but those three practical things that will apply to all patients about not solving the wrong problem, breaking the base rate, and that a central retinal detachment can mimic this condition. Really, really cool practical pearls. Thank you. All right, Jas, take it home, please.
All right, everyone. First of all, Kara, thank you for bringing this fantastic case while you're sleep deprived. We will appreciate the learning. I tried my best to capture all of this. So let's begin. So we initially started with a generic approach to conjunctivitis, which Reza pointed out that, common things being common, allergic, irritant, viral, or bacterial needs to be first looked at. However, Reza pointed out that the recurrent flares in this patient was definitely something, a nidus where we take a step back and ask, why are we dealing with the recurrent red eye? And almost all conjunctivitis, Rabih reminded us that even bacterial conjunctivitis heals without antibiotics or treatment. So the fact that this is recurrent is another clue of a systemic or more of a ominous etiology. In addition to conjunctivitis, three other benign conditions of the red eye was blepharitis, subconjunctival hemorrhage, and dry eye syndrome. However, when looking at these benign conditions, you should not have any type of eye pain or loss of vision. And then Rabih beautifully laid out that because the eye or the conjunctiva or the cornea is basically being inflamed, it should have discharge or oozing. But so if it does not have that, that is also a red flag. He also explained that if there's central conjunctival irritation, that is another possible clue for uveitis or another sinister etiology. Then Reza went over the eye anatomy, which is important for further clues. Is this a scleritis, episcleritis, or is this conjunctivitis? And if you do see any of these situations, then this is another clue for anterior eye pathology, but still does not rule out posterior chamber pathology. And then diplopia is something that we often confuse with blurred vision, but the true definition of diplopia is misalignment of the eyes secondary to some type of extraocular muscle dysfunction. Another clue we got here was the localized headache, that this may give a clue to the posterior chamber of the eye being involved, especially because the eyes is the gateway to the brain. So what things popped to our head when we think about the posterior chamber of the eye? So that is optic neuritis, retinitis, posterior uveitis, and what we learned today was bilateral serous retinal detachments. So the other thing that Rabih mentioned was, could this also be a panocular disease given the visual loss, the lack of discharge, and localized headache? And want to start off with basic labs with RPR, chest X-ray to look for sarcoidosis or evidence for sarcoidosis and HIV. And then we saw a great picture that showed optic disc swelling. So the approach to that, is this bilateral or unilateral? Is this pseudopapilledemia like hyperviscosity syndrome, thyroid disease, or hypertension? Or is this true papilledema like idiopathic intracranial hypertension, mass lesions, etc.? And then Rez also mentioned that it's important to consider venous cavernous thrombosis in this situation, in this patient, especially with her being on an OCP. However, Rabih also mentioned that optic neuritis is something that could fit well as well, given the fact that the present, and if it was unilateral, you want to most definitely include or exclude inflammatory etiology. For example, infections, autoimmune, demyelinating conditions. Even though this was bilateral, a systemic infection could still be possible, but an autoimmune condition that would isolate itself to the CNS system is less likely. So we learned today that the findings on the ultrasound of the posterior chamber was something called an exudative or serous retinal detachment. So I Googled this definition, and this is a learning point for me, so I hope this is beneficial for others as well. It occurs when fluid accumulates in the subretinal space between the sensory retina and the retinal pigmented epithelium, resulting into the actual detachment. Causes for fluid accumulation to include either inflammatory, infectious, or neoplastic disease of the choroid or the retina. And I can't pronounce that, so I'm just going to say VKH disease. We learned was an isolated, rare CNS disease that can lead to visual and hearing loss, and it is usually a diagnosis of exclusion.
Jazz, thank you so much. You can just tell that your chief year has paid off tremendously, and you as a teacher, like the way you structured this and the way you deliver it in your cadence. So thank you for that. Truly superb. Just quick question for the group. What do we have tomorrow? What can we plug for tomorrow?
Tomorrow's Saturday.
I know,
Tomorrow,
but we
oh
have
my
probably
gosh, no,
something.
I was orienting myself. So tomorrow we are having a CP Solvers Academy VMR in the afternoon. So CP Solvers team members get to we hang out, and it is a behind the scenes VMR where there will be a story told from Japan. For those of you who are tuning in on YouTube or hanging out here, we'll be back on Sunday for student VMR. For those of you who are on the team, get ready for a roller coaster from Japan. Sushi will not be involved, disappointingly. I'm sorry. Jas, that was amazing. Thank you. And Kara, drive safe. I'll see you soon. Bye, everyone.